بسم الله الرحمن الرحيم. السلام عليكم صباح الخير. I am Dr. Mohamed Adel, assistant lecturer at the Armed Forces College of Medicine, and I am truly honored and very thankful to Professor Dr. Hind Dean for this prestigious opportunity to present the topic of my thesis at such a conference. So the title of our research now it was a combination of fetal pulmonary artery indices with the volumetric fetal lung measurements. So why do we say indices and not Doppler indices? Because there are some measurements such as the diameter included for the assessment of the pulmonary artery. And here the main topic of our paper was to measure the volume of the lung in 2D measurements. In most advanced countries, the 3D machines and the 4D machines, and as Dr. El-Adi just illustrated before me, they are now widespread. But we have to stick to the basis and to know how to perform the fetal anomaly scan in 2D basis, then upgrade our skills by the 3D, 4D images and live scan for the baby. And actually, I'll give you a very important tip which helped me through the process of learning fetal anomaly scans. You have to correlate the ultrasound and even the CT and the MRI. So you don't look at any anatomical organ in the body in just one modality. It would be better for you to correlate with MRI images, such as the CENI images, and get used to the fetal images of MRI, and even the adult, get acquainted with the basic views, such as the 4-vessel views, the 3-vessel views, and the 4-chamber views. Those are very good tips to perform the scan. So, in our study, the 2D lung volume measurements, we had two ways. Moglen presented a way for the 2D lung measurement, which included the main measurement of the fetal lung area and the height. Those are the two main objects to measure for the lung volume measurements. And we have the second, and he considered, Moglen considered the lung as a triangle. The second way is a Roger-Jonier formula, and he estimated the lung as an ellipsoid volumetric shape. So he presented this formula, which includes the basic measurements of the lung height and length and AB diameter. So this is very similar to any volume measurements that we perform in the ultrasound by far. The second item is to measure the pulmonary artery Doppler indices. So in which views do we measure the pulmonary artery Doppler and measure its diameter? So you have two options, because as we all know that the fetus can be so mean and it keeps rotationing, so you don't always get an optimum view. So even you can measure the pulmonary artery in axial view, or in the RVOT, which is sagittal or even slight parasagittal view. So the objectives of our study was to measure the fetal lung volume using the 2D measurements. Number two is to measure the pulmonary artery Doppler indices and the pulmonary artery diameter, and to combine the results of each fetus and correlate it with the clinical data. In this case is the UPCAR score assessment and the neonatal admission to the ICU. And even if he needed any respiratory helping modalities, such as oxygen mask or CPAP or even mechanical ventilation. So the total patients in our study were 170 patients. Of them, there were about 21 exact cases which recorded fetal respiratory distress. Those were our inclusion and exclusion criteria. Our inclusion criteria was to include a normal pregnancy. So a mother with no risk factor, no known risk factors. So we excluded anyone who had diabetes, hypertension, and any chronic disease or even pregnancy-related disease. So those are the basic measurements which we performed. So first we have the axial 4-chamber views of the heart. This is the optimum view to measure the AB diameter and the transverse diameter of the heart, of the lungs. And then you have two options for the measurements of the height. Either in the sagittal view, which is slight right or left parasagittal to get the measurement for each lung, or in the coronal view. So whichever is convenient during the scan, you can perform it. The third measurement is the area, which is also performed at the axial view of the heart, including the 4-chamber views, and and this is our role while assessing the heart. So we, as Dr. Wael said before me, this is the aorta. So in front of it we have the left atrium, left ventricle. You go to the right side, you have the right ventricle and the right atrium. So you have to get acquainted to this view. So the two main formulas, which I discussed before, are Moglen's formula, and he estimated the lung as a pyramidal in shape, and Arujo Jr. formula, which he estimated the lung using his formula as an ellipsoid shape. So the common features are the measurement of the lung height. So the special about Moglen's formula is that we have to measure the lung area, and for Arujo Jr. formula, we will measure the AB and transverse diameters. And this is a view for the measurement of the main pulmonary artery diameter, and even to apply the Doppler. So this is the main pulmonary trunk and the bifurcation into the right main and left main pulmonary arteries. The Doppler indices which we relied on were the resistive and pulsatility index, acceleration time, and ejection time. So the pulsatility index and the resistive index, I think that we are all familiar with. Acceleration time is the time from the beginning of the systole to the end of the to the peak systolic velocity. Ejection time is the time from the beginning of the systole till the end of the diastole. Those measurements, we measure it manually on the Doppler screen. So when you perform Doppler, you begin to measure those. Don't let the machine do it automatically because it's not very accurate. It's better to get used to it, and if you remark that your machine is accurate in the automatic measurements, you can then rely on it. After that, the clinical assessment was used by using the upgrade score sheet and performing BA chest X-ray for those fetuses who entered the NICU. So the results, about 12.5% of the patients, they showed respiratory distress symptoms. One of the main significant correlations to the fetal respiratory distress that we noticed was the gestational age, and this is well established in the obstetrics field. The second was the corticosteroid regimen, and this differs from one hospital to another, one country to another. So in our hospital, the corticosteroid regimen for the full lung maturation is composed of 4 doses, 4 equal doses of 6 milligrams. So you have to get acquainted also with the corticosteroid regimen used by the obstetric and gynecology department at your hospital, because some use like 2 doses of 12 milligrams or 3 doses of 8 milligrams. A total dose of 24 milligrams is well established in the field. The third is the mode of delivery, and this showed some differences from other literatures, because nowadays it's the standard that mothers request for the corticosteroids for the fetal lung maturation. They are afraid of the consequences to have a baby, and he complains from respiratory distress entering the NICU and so forth. So they do it as a prophylaxis form. We also remarked that there was a slight female gender prevalence. The expected fetal weight was one of the significant items which showed correlation with the respiratory distress, and this is well established in the literature. Acceleration and ejection time showed also significant correlation with the progression of fetal respiratory distress, and some papers also they presented that the acceleration ejection time ratio was very significant, but this really depends on the volume or the sample volume that they used. For the fetal lung volume measurements, using the 2D formulas, the Moglins and the Arujo Jr. both were significantly correlated to the fetal respiratory distress. What we remarked is that the fetal lung length, which is the AP diameter, the width, and the area, they also individually represented or showed significant correlations to the progression of fetal respiratory distress. And here is a cut-off volumes using each formula. So for some case presentations, this was 38 weeks gestational age pregnant female. She didn't receive any form of corticosteroids and had a normal vaginal delivery. Those are the views which I explained before for the measurements of fetal, the lung measurements. This is the Doppler images, and the Doppler indices are measured. So we have here the ejection time, acceleration time, and we draw or we trace the peak of the systole and the diastole to get the BI and the RI. This was a completely normal patient. Second patient was a 36 weeks pregnant female, and she didn't receive any form of corticosteroids, and she had normal vaginal delivery. Those are the measurements of the fetus lung and the pulmonary artery Doppler. This fetus, he had, and this is a retrospective analysis after we finished the study. So this was under the cutoff value which we found, and this fetus had a respiratory distress. He had a PA X-ray, an AB X-ray, I'm sorry, which showed like reticulonodular opacities. They slightly scattered reticulonodular opacities, but the fetus, he went into the NICU. Another case, 38 weeks pregnant female. She also didn't receive any form of corticosteroids and had normal vaginal delivery. Those are her fetus assessment. And this fetus had a decreased lung volume and a decreased acceleration and ejection time. And this is his AB chest X-ray. Fourth case is a 37 weeks pregnant female, and this patient had a single dose of corticosteroids, and she underwent cesarean section. Those are the lung measurements. Doppler assessment. Her fetus had only decreased lung volume below our cutoff, but he also went into the NICU. He had AB chest X-ray, and which showed bilateral lung opacities, but he didn't have pneumonia. It was respiratory distress. Fifth case, 38 weeks old female. I'll just keep the pace up to catch the time. This fetus had a decreased lung volume and decreased Doppler pulmonary artery Doppler indices. And reticulonodular shadows are seen in, of the AB chest X-ray. So every research paper has a limitation. So ours was the limited representation sample volume. So 170 patients is quite good to like have a paper published and so on, but to establish national-wide parameters, the sample volume had to be larger, very larger. So our recommendations. Number one, as I said, is to increase the sample volume. Those are like research ideas, and to keep the work on from where others is, ended. By the reviewing of the literature, there are many well-established charts for, like I think in Italy and China had one. So it would be a good idea for to have an Egyptian nomogram for the fetal lung, pulmonary artery Doppler indices, and so on. This has a very significant in the clinical assessment. Number two is to include and stratify the patients according to the pre-term, term, and post-term. This would give an insight, depth, detailed analysis for the results after they come. And this was a limitation in our study, which we had a wide spectrum look of all the patients. We didn't categorize them into like full term and post-term and the pre-term. This was not included in our study. The third is we found that the lens width and area individually showed significant, so significant correlation to the fetal respiratory distress. So we recommend further analysis to establish those hypotheses. And we also used Aroja Junior and Moglen's formula. So also a good idea would to be to investigate which is more significant and which is more accurate. And this would happen if we compare it to an objective study such as the fetal lung MRI during pregnancy. And this is what I said before, is to establish an Egyptian nomogram for all the fetal like measurements, lung, heart, femur length, and so on. So the conclusion, we found by the combination of the fetal lung, 2D lung volume measurements and the main pulmonary artery Doppler indices, we found that there would be an overall higher specificity for the detection of the fetal respiratory distress. This is all, and I'd like to thank you very much.
Thank you, Dr. Mohamed, for the nice talk.